Good morning, my name is Lisa, and I'll be your conference operator. At this time, I would like to welcome everyone to the Shoot for the Stars conference call. All lines have been placed on a listen-only mode. Later, we will conduct an interactive question-and-answer session. If you would like to ask a question during that time, simply press star and the number 1 on your telephone keypad. You will hear a tone acknowledging your request and a prompt to record your name, so please make sure your phone is not muted. If you would like to withdraw your question, please press star and the number 2. It is now my pleasure to turn the call over to Melissa Miranda. Ma'am, you may begin your conference.
Thank you, Lisa. So good morning, everyone, and thank you for joining us today. My name is Melissa Miranda, and I'm going to quickly review a few housekeeping items before we introduce today's moderator, Danielle Watford. This webinar will be recorded, and the presentation will be available within a few business days. As Lisa mentioned, the phone lines are on mute for the duration of the presentation, and so we ask that you do not place us on hold during that time. If you do have a question at any point throughout the presentation, you can enter it into the chat panel to the right of your screen. We will be monitoring and responding to questions and comments in chat, as well as have time for questions at the end of the presentation. I want to mention that a follow-up webinar is scheduled for December 1st at 11 o'clock. The follow-up webinar is meant to answer any additional questions that you may have after the presentation was given and you've had time to digest the information and consider how it applies or impacts your work. So please join us for that on December 1st. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. So again, thank you for being part of the New England Nursing Home Quality Care Collaborative. Maybe you don't know, but this is a collaborative of over 660 nursing homes across New England focused on quality improvement. That means that the QIN-QIO is providing some level of support to about 70% of nursing homes in New England in the following ways. Through technical support related to quality improvement, either by telephone, email, or on-site visits, the QIO can help identify strategies for your QAPI plans. Through monthly QAPI calls that will be starting in January will help QAPI come to life in your organization. We support you by collaborating with the long-term care stakeholders, both statewide and regionally, ensuring synergy of focus and key messages, and to bring educational opportunities to you. We're making education available when you need it through this virtual learning series of webinars that includes subject matter expertise, resources, and best practices that result in improvement. We're also providing you with data to help track, trend, and monitor areas of strength and to identify the opportunities for improvement. And one of the most important opportunities I'd like to mention today is that we can share with you access to our Patient Family Advisory Council, whose members are patients, residents, and family members throughout New England. So consider how a group like this might be helpful to you. We know that education and an informed staff is key to success. It's imperative that your teams stay abreast of best practices, systems changes, and industry news, and we want to continue to be a resource for you. All that said, let's get underway with today's topic of discussion. I'm happy to introduce Danielle Watford, who's a member of the QIN-QIO team and supports nursing homes throughout the state of Maine. Hi, Danielle.
Hi there. Thank you so much, everybody, for being here. I just quickly want to go over what you can expect in the next hour. So we're going to look at, obviously, identifying ways that the New England QIN-QIO can support you. Melissa was able to share some of that just now. We're also going to look at being able to fully understand the current 5-star rating system as it exists. We're going to know how the most recent additions to the nursing home quality measures are impacting your 5-star score. We're going to describe the impact and implications of your star rating on quality and payment. And then we're going to strategize on plans so that improved care coordination can positively impact your patient outcomes and facility measures. So that's kind of a brief idea of what the next hour will entail. So what we already know about the overall 5-star rating, we know that it's based on 3 factors: your health inspection, 5-star, your staffing, overall 5-star, and then your quality measures, 5-star. I'm just going to briefly go over each topic, and then we're going to get into the 6 new quality measures that were released in July and subsequently in August that affect the 5-star. So your health inspection rating, those take into account 3 years worth of QIS survey results, with the most recent survey being weighted more heavily than the ones further back. So the score or the rating that you have on your health inspection for the last 12 months are going to count for about half of the total points for that 5-star rating, with the year prior to that being about a third, and the third one being about a sixth. So obviously the most important survey is going to be the most recent because it's going to have the largest weight. Your score is going to be based on weighted deficiencies, with scope and severity playing a role in how many points are attributed. The more severe the finding and the larger the scope, otherwise known as the more residents that are affected by it, are going to give you more points in that area, and that's ultimately going to drive down your 5-star rating on this measure. So lower severity and lower scope will not hit you, for lack of a better term, as much as higher severity and higher scope. This measure is a state-specific distribution measure, so when you have your overall score, so those points that you get based on scope and severity based on your QIS survey, it'll be based on the comparison of other nursing homes and facilities within your state, with the top 10% of facilities in each state receiving a 5-star, the middle 70% receiving a 2, 3, or 4, depending on where they fall on the point spectrum, and then the bottom 20% receiving a 1-star rating. It's not just your QIS survey that this measure is looking at. It's also any kind of complaint investigation that happens. So that is looking at anything in a 36-month review of complaint investigations, and they are staggered in weight similar to the QIS survey, with the most recent rolling 12 months being weighted heavier than those in a 24 or so 36-month window. And it will also look at any revisits on a plan of correction. So if you put a plan of correction in place and they come out and clear you of that deficiency, then that will play a role in your overall star rating, similar to your overall QIS survey results. If they have to revisit you multiple times because they don't clear you in that first visit, those revisits will negatively impact this overall rating. So possible changes to the health inspection measure. So these are things that could impact how this measure is represented. That's going to be any time you have a new health inspection or a new complaint deficiency found, or a second, third, or fourth revisit, which is what I had just mentioned. Also, the conclusion of any informal dispute resolution. If your nursing home, if you are found to have a deficiency that your leadership team doesn't feel is warranted, you can obviously file an informal dispute that will go in front of a panel to review the information from the survey team and also from your leadership team, and they'll make a decision on whether or not that deficiency stands. If the deficiency is overturned and taken off your findings, that result will impact your health inspection measure. Or the aging of a complaint deficiency. Complaint deficiencies age similar to how they're distributed over a 3-year period. So after the 36th window, that complaint deficiency will fall off or age.
Hey, Danielle, this is Melissa. I just wanted to know how you want to handle the questions in chat. Do you want to wait till the end?
That might There's a lot to cover, so it might make sense, unless it makes more sense to go if they're specific to what we're reviewing right now.
Yeah, they seem to be.
Okay, then we can do that now.
Okay, so I think from the first slide, we got a question from Chris Ryan. What should the total score be to obtain a 5-star, 4-star, etc. under the state survey portion?
Is that question related to the total number of points, as in for an overall quality measure, in addition to your health inspection? Is that the question that's being asked? If you include your quality measures, your staffing, and your health inspection, what would be the total number?
Yeah, I think we're going to have to wait till the end then and get the people on the line to clarify. So why don't we...
Okay.
We'll just keep going and then address all of the questions at the end.
Okay.
All right, thank you.
Yeah. So the next factor that plays into your overall 5-star rating is your staffing measure. Your staffing measure is based on 2 case mix adjusted measures, the total nursing hours per resident day, and then also your RN hours per resident day. Total nursing hours would include RNs, LPNs, and nursing aides, where RN hours are only looking at registered nurses. So this just represents that RN hours, your registered nurses, your directors of nursing, and your nurses with administrative duties. Don't forget those, the folks that submit your MDSs. Those can be included in these RN hours. And obviously the nursing aid hours include med aides and technicians, also aides in training, and certified nurses. This isn't just staff nursing. This could also be agency staffing. So make sure that when you're putting this measure together, that you're including when you're using agency staff, because those folks do count towards your overall staffing number. So when do updates occur? MDS-based quality measures are updated on a quarterly basis, and the updates are occurring mid-month. So that's January, April, July, and October. And the claims-based quality measures, and these are obviously the new quality measures that came out in the last 6 months of this year, are updated every 6 months, April and October. Changes in the quality measures may change your star rating, your overall star rating. So now we're going to look at the changes to the 5-star rating that occurred in July of this year and then went into effect in August. There were some methodology changes that happened. Methodology changes included that now they're using a 4 quarters worth of data rather than 3 for determining quality measures, quality ratings. They're also reducing the minimum denominator for all measures so that those smaller homes will be able to have a better idea of where they fall in relation to the larger homes. And they're also using national cut points for assigning points for the ADL quality measure rather than the state-specific threshold. In terms of the new quality measures, I've outlined those here. Those in red represent the quality measures that are actually going to affect your 5-star rating. The last one, the percentage of long-stay residents who received an anti-anxiety or a hypnotic medication, is not being used as a part of your 5-star measure because it hasn't been validated in a way that CMS feels they can actually put it towards the 5-star rating. So at this point, these 5 in red are the 5 that have been added to contribute to your overall 5-star rating. And they include residents who are rehospitalized after a nursing home admission, short-stay residents who had an outpatient emergency department visit, short-stay residents who were successfully discharged to the community, all of which are claims-based measures, short-stay residents who made an improvement in function, and then long-stay residents whose ability to move independently worsened. We're going to go into much greater detail for each of these measures. So weighting of the new measures. In July of 2016, the new measures are only counting about 50% of the weight of the current measures. The current measures that we have count 100 points towards the total, which kind of goes back to the question that Melissa had brought up. How many total points do you need to get a 5-star rating? That's what we're talking about here in terms of points. And the new quality measures are only going to have an availability of 50 points till the end of 2016. As of January 2017, the new measures are going to have the same weight of the current measures, or the possibility of 100 points total. So the review periods for the new and the old quality measures. For the claims-based measure, these are the hospital readmission, the ED visits, and the community discharge measures. Those quality measure points are going to be based on data from 2014 quarter 3 through 2015 quarter 2. So this is relatively old information or older data dating back. For the MDS-based measure, all the other measures, the points are based on data from all of last year. This diagram just shows you how new quality measures come into play, the development phase or enhancement, the specification process, the testing and reevaluation, the NQF process, and then how they actually go through review to the point where it actually gets enacted into the 5-star rating. So I thought this was a good way of showing you that obviously these measures have been tested and validated through and through. And that's why they have now landed on your overall 5-star rating. So we're going to go into each of the new measures now in greater detail so that you have an idea of who is included in this measure and what the exclusions are. So first we'll look at the percentage of short-stay residents who are rehospitalized after a nursing home admission. This is a claims-based measure, and claims-based measures are pulled from bills. They're going to be looking for folks, short-stay folks, who were rehospitalized after the nursing home admission within 30 days of entry or re-entry. And planned inpatient readmissions are excluded. Some of the planned readmissions include organ transplants, maintenance chemotherapy, planned knee replacements. Those are just some of the planned inpatient readmission diagnoses that are excluded from this measure. So this rehospitalization who count, those that count are going to be beneficiaries who meet the inclusion or exclusion criteria for the denominator and were admitted to an inpatient stay or observation stay within 30 days of entry or re-entry to the nursing home, regardless of whether or not they were discharged from the nursing home prior to the hospital readmission. So this is really important to keep in mind that those folks that are in your scaled units that go to the hospital for something that could be completely unrelated to the admission criteria that brought them to your facility, if they go to the emergency room and are subsequently admitted to the hospital, they are going to count in this measure, in this quality measure for you. It's not that they have to be discharged from your facility to count. They can actually go from your facility, be admitted to the hospital, and then come back to you and count in this criteria. So the total number, which is going to be your total population of folks that were admitted or readmitted to a nursing home within 1 day of discharge from an inpatient hospitalization. And these hospitalizations are identified using Medicare Part A claims. And exclusions, many of the exclusions, so these are going to be the folks that do not count in this measure, are the same for the next 3 quality measures. So I'm going to go through relatively quickly after this slide, but those exclusions are going to be residents that did not have fee-for-service Part A or Part B Medicare enrollment for the entire period, those that were ever enrolled in hospice care, those that were comatose or missing data on the comatose question of the MDS assessment, or data was missing for any of the claims or MDS items used to construct the numerator or the denominator. And those residents that did not have an initial MDS assessment to use in constructing it. These exclusions are very similar for each of the next 3 measures. Percentage of short-stay residents who have had an outpatient emergency department visit. This is looking at those residents who ended up in the emergency department within 30 days of entry or re-entry to your nursing facility, but did not result in an inpatient hospital admission or observation stay. The folks that are going to be counted, again, are going to be those that were admitted to the emergency department regardless of whether or not they were discharged from the nursing home prior to. So again, it's really important to keep in mind that this measure is looking at folks that not only discharge from your facility and go to the emergency department, but also that are sent out from your nursing facility and go to the emergency department while they're in your care. The folks that count, very similar to the last measure, anyone who entered or re-entered the nursing home within 1 day of discharge from an inpatient hospitalization, and who entered or re-entered the nursing home within the target 12-month period. So that's the total population of folks that they're going to be looking at. Exclusions, very similar, identical to the last measure. No fee for service, wherever enrolled in hospice care, were comatose or had missing data on that item in the MDS, were missing any of the claims or MDS items used to construct the numerator, or they did not have an initial MDS assessment to use to construct the risk adjustment. The percentage of short-stay residents who are successfully discharged to the community. This measure is basically CMS's way of making sure folks leave your facility before the 100th day. So this is a claims-based measure, again, determining the percentage of all new admissions to a nursing home from the hospital where the resident was discharged to the community. Those that are going to be included in this measure had a discharge assessment indicating discharge to the community within 100 days of the start of the episode, were not admitted to the nursing home within 30 days to the community, did not have an unplanned inpatient hospital stay, or did not pass away within 30 days. So basically what they want is folks to go home within 100 days and stay home at that lowest level of care without having to bounce back to either the emergency room, return to the skilled setting, or be admitted to the hospital. Total folks that will be used in this measure, again, include anyone that entered the nursing home within 1 day of discharge from an inpatient hospitalization, and these hospitalizations are identified using Part A claims, or that entered the nursing home within the target 12-month period. Exclusions, identical to the prior two measures, fee-for-service Part A, hospice, comatose or missing data, claims, missing any claims on the MDS items used to construct the numerator, or did not have an initial MDS assessment. Short-stay residents who made improvements in function. This is where the measures get a little bit different. This is an MDS-based quality measure. We've been talking about measures that are billable in nature, and now we're going back to what we kind of know from experience, which are those measures based on our MDS submissions. And so this measure is an MDS-based quality measure that assesses the percentage of short-stay folks, those folks that are with you less than 100 days, with independence in 3 mobility functions, transfer, locomotion, and walking, increases over the course of the nursing home care episode. Basically, CMS wants to know that folks are improving when they're in your care on these 3 areas. So those that count, these are folks that have a change in performance score that is negative using the earlier assessment if resident has both a 5-day and admission assessment. Performance is calculated as the sum of transfer self-performance, locomotion on unit self-performance, and walk in the corridor self-performance. So basically, if your resident is assessed at a higher rating on their 5-day and admission assessments than on their next MDS assessment, they're going to trigger for this measure for you. They want to see that your residents are improving in function while they're in your facility for short stays for folks that are less than 100 days. Total folks that they're looking at are those that have a valid discharge assessment and have a valid preceding 5-day assessment or admission assessment. So it's pretty much everyone. And then exclusions, slightly different than the last 3 we've been talking about. The resident was comatose on the 5-day assessment, had a life expectancy of less than 6 months, was in hospice on the 5-day admission assessment, had no impairment on the 5-day admission assessment, had an unplanned discharge during the care episode, or there was data missing for any of the MDS items used to construct the numerator or denominator. Percentage of long-stay residents whose ability to move independently worsened. So this is our first long-stay resident new quality measure, and this is again an MDS-based measure, and it's looking at the percentage of folks who experienced a decline in independence and locomotion. Those that count are going to be folks that have a decline in locomotion when comparing their target assessment with the prior assessment. A decline is identified by an increase of 1 or more points on the locomotion on unit self-performance between the target assessment and the prior assessment, with sevens indicating activity occurred only once or twice, and 8 activity did not occur. The total population of folks that they're looking at are going to be any resident that had a qualifying MDS assessment during the target period, including annual, quarterly, significant change, significant correction, or discharge assessments. So that's pretty much all of the assessments. Or have had at least one qualifying prior assessment, which included admission, annual, quarterly, significant change, or significant correction. Exclusions, those that would not count in this measure are residents who were comatose, had a prognosis of less than 6 months on the prior assessment, was in hospice on the prior assessment, was totally dependent in locomotion on the prior assessment, or were missing data on locomotion on the target or prior assessment. The last measure, and remember, this is the measure that is not going to be taken into account when figuring out your overall 5-star rating or your quality measure 5-star rating that contributes to your overall rating, because it hasn't been fully validated at this point, is the percentage of long-stay folks who received an anti-anxiety and hypnotic medication. Again, another MDS-based measure. And those that count are going to be long-stay residents, folks that are in your facility more than 100 days, that have a target assessment where anti-anxiety or hypnotic medications are received. So basically, if you are checking yes that they haven't received this medication, that would be a resident that would count on this measure. This is going to be out of all long-stay residents for the target assessment included in that measure, so basically everyone. And exclusions are going to be residents who were comatose on the prior assessment, had a life expectancy of less than 6 months, was in hospice on the target assessment, anti-anxiety medication received item was missing, or hypnotic medication item received was missing. So that means that was not answered on the MDS. So how do I figure this all out? We've kind of gone over the staffing in brief. We've gone over the QIS survey in brief, and now the brand new quality measures that contribute to our overall quality measure. So I just want to talk quickly about how to kind of figure out how we tally up our overall 5-star rating. The first step is you're going to start with your health inspection rating. This is kind of where everything lives. So if you start with a 2 on your health inspection rating, you're going to next look at your staffing rating. You're going to add 1 star to the health inspection rating if your staffing rating is a 4 or a 5 and greater than your health inspection rating. So, for instance, if you have a health inspection rating of 2, but your staffing rating is a 4, you're going to add a star, bringing you up to a 3. You're going to subtract 1 star if the staffing rating is a 1 star. So if you're a 2 in your health inspection rating and a 1 in your staffing, you're going to go down to a 1-star rated facility. The next step is going to be adding 1 star for your quality measures if your quality measure rating is a 5. So if you started with a 2 in health inspection, you had a 4 in staffing, that makes you a 3, and now you have a 5 in quality measures, that brings you up to a 4-star overall rated facility. You're going to subtract a 1 star if the quality measure rating is a 1. If the quality measure overall rating is a 1 and you started with 2 for health inspection, added 1 for your staffing because you are a 4-star rated staffing facility, but you only had 1 in quality measures, you're going to remain at a 3. Keep in mind that if the health inspection rating is 1 star, then the overall rating cannot be upgraded by more than 1 star based on the staffing and the quality measure rating. And if the nursing home is a special focus facility that has been gradated, the maximum overall rating is 3 stars. So now what? So how do we create safe and successful transitions? Basically, the three new measures for the quality measure score are really looking at how well you plan for the discharge of your short-stay residents and how well you respond to the needs that they're going to have in the community, and you collaborate with your community providers to make for safe transitions back to the community. So what we're really looking at is the use of multidisciplinary case management. This is obviously a process involving physicians, nurses, social workers, and other health professionals in order to keep the resident at the lowest level of care and successful in the community once they discharge from your nursing home. The best defense to improve and make sure that you maximize the total opportunity for these new quality measures is to coordinate with all the folks that are going to touch the resident. So that's going to include their outpatient physicians, their PCPs, and their specialty providers. You're going to include the patient and their family as a primary partner in this process. You're going to look at nursing home staff, the physical therapists, OT, social work, and speech therapy, all to help create a treatment plan once they're discharged to the community that keep them at home safely without requiring higher levels of care. There are opportunities for collaborating with your hospitals through their case managers, your discharge planners, your emergency departments, and your hospital physicians. They're going to be those folks that see the patient when they come into the emergency department or that work on discharge planning if they do unfortunately end up in the emergency room or in the hospital for an acute stay. Other post-acute care providers, your home health agencies, your physician practices, your insurance companies. Many insurance companies now have case managers that will help their clients through the process of discharges. Your community partner agencies, your area on aging, vendors, business partners, and your ACOs. Obviously, the public and the patients and the families would also be one of your number one sources of collaboration to help with these measures, these billable-driven measures. So now I just want to mention the new reform of requirements for long-term care facilities. We all know that this went live as of October 4th, and there were some specific language put into that regarding case management and care coordination. And I just wanted to mention that in brief so that folks are aware of it, so that we can keep it in the forefront of our mind around transitions of care. And I have put the page numbers on here so that if you've had the opportunity to read the 740-page document, by all means, you can find this here. The transfer or discharge must be documented in a residence chart and appropriate information communicated to any of the receiving settings, many of which are referred to on the last slide, including home with home health services, hospice, assisted living, including 18 specific items that are listed in that reform of requirements. Also, when the resident's being transferred for the resident's safety and welfare, in addition to those previously mentioned 18 items, the center must document the specific resident needs it cannot meet. So those are two new areas of reform that are now required as a part of our documentation process. I'm going to guess that many folks are already covering the 18 specific items they're talking about. It just means now we need to make sure we're really specific that we're meeting those in our electronic medical records or in our hard copy. So that's the information that I have. I do want to note that on our website, which is healthcarefornewengland.org, we have updated our quality measures manual, which Pam Heckman, our nursing home representative from New Hampshire, has really taken the lead on. You can find that by going to the website under healthcarefornewengland.org. You're going to click at the top where it says for providers. It's going to drop down to a series of levels of care, and you're looking for nursing homes. And under nursing homes, once you click on nursing homes, it's going to bring you to an option for tools and resources. And at the very bottom, you're going to find that quality measures manual. So that way you can actually reference all of this information in much greater detail. So I think now we'll open it up for questions.
Lisa, can you remind everybody how to ask a question?
Yes, ma'am. If you would like to participate in the interactive question and answer session, please press star and the number 1 on your telephone keypad. You will hear a tone acknowledging your request and a prompt to record your name. So please make sure your phone is not muted. We'll pause for just a moment to compile the Q&A roster. Again, that is star 1.
So we'll just give it a second to see if anyone gets into the queue to ask a question, and then if not, we will address the questions right in the chat.
You do have a question from Drusilla Boyani.
Hello, how are you?
Good morning.
Good morning. A question, when you said the outside complaints would be factored into the 5-star rating, what if they were not substantiated? Would they still be included?
So these are going to be complaint investigations that result in a substantiated finding, similar to the QIS survey. Yep.
Okay, thank you.
Sure, you're welcome.
Your next question comes from Lisa Messer.
Hi. The question that I have is, will we have a download of this presentation so we can get our other nurses up to date on this?
Yes. Morgan, do you want to point out?
Yes, so this is, in the chat we put a link to the presentation, but it did go out this morning with a reminder email. So this was a reminder email about this webinar that has a link to the slides, but Morgan also placed it right in the chat, so you can access it there.
Okay, thank you very much.
Recorded webinar will be sent out in a couple of days.
And your next question comes from Donna.
Hello?
Hi, go ahead and ask your question.
My question was actually answered, but I have Carrie here with a different question.
How can I find a complete definition for planned readmit without exclusion list?
The complete definition for planned readmissions?
Yeah.
You can either go to Healthcare for New England and where I referenced before, go to providers and then tools for nursing homes, and you'll find our quality measures link. And if you go to the appendix of that document, you'll find the new quality measures with a much more detailed definition list in that document. You can also go into CMS, and CMS has a much broader quality measure report that you can access as well.
And Danielle, I just put that link in chat.
Perfect.
Lisa, do we have any other questions?
Oh, yes. Yes, ma'am. You have one from Christopher Ryan.
Yes, hi. This is Chris Ryan. I have a question regarding the weighted deficiencies and the scope and severity. On slide 7 and 8, just I want to make sure I understand this. If you tally up your total points over a 3-year period regarding your surveys, and then you add those all up based on, the half, the 1/3, and the 1/6 over each of the periods, that total number is compared to your state facilities to see where you rank in your, percentage breakdown. Does that make sense?
Yes.
Okay, so, all right. Excellent.
Yep, so you can look at what your total points are based on the scope and severity of the 3 years and how they're weighted. And so this is a state compared measure. So you're going to be looking at the top 10% being in the 5-star range, the next 70% being in the 3, 4, and 5 tiered, and then the lowest 20% being in the 1-star range.
Great, thank you.
You're welcome.
And you have a question from Mary Ellen.
Hi.
Hi there.
Hi, go ahead and ask your question. Thank you.
What I was wondering, in the quality measures, one of the inclusions, you had stated was if a patient was discharged home, but within that 30 days went back to the ER and was admitted. If they wanted to come back to that same nursing home that they were initially discharged from, is that a negative impact on the nursing home?
So you're wondering if you discharged a patient from your facility, they ended up going to the emergency room, and from the emergency room, rather than be admitted to the acute care setting, they went back to your facility?
Right.
That's still going to count on your emergency room quality measure, because this is a billable driven, so any bill that is in response to an emergency room visit would still count.
Regardless of whether they were discharged from the nursing home to home.
If they discharged from the emergency room to home and then went from home to the emergency room, it would count.
Okay. All right, thank you.
You're welcome.
And you have a question from Dante.
Hello.
Good morning.
So, if we have a resident who is skilled, they are adamant about going home. We issue an AMA, and they go home. They get re-hospitalized within 2 weeks, even though we issued an AMA. Does that count against us?
That's a really good question, and I, to be honest, am not sure. I'm going to write that down, and I'll get your contact information, and I will follow up with folks, because I'm not sure. I would suspect that, yes, it is going to count against you, even though you issued the AMA, but I don't want to say that without knowing for sure. So let me write that down and follow up. Thank you. It's a good question.
And there are no more questions in the queue at this time.
Great. So, Danielle, I'm just going to read a couple of the questions here in the chat. There's a question from Drusilla. If the outside complaints were unsubstantiated, do they affect our 5-star quality measure?
So I believe that is the same question from before. So the outside complaint would need to have a substantiated finding in order to, a substantiated deficiency that was found in order to count in your total QI at your survey quality measure. If they came out on a complete investigation and there were no findings, it's not going to count against you.
Great. The next question is from Linda. It says, long-stay nursing home residents are expected to eventually lose abilities. That is why they're in the nursing home. So why then is this a measure?
Well, you're not the first one to ask that question. I think everybody that I've done this presentation for has asked that same thing. The one thing I can say is that once a resident has already shown the decline, for instance, on a quarterly, that next quarter, then you're not going to have them trigger for this measure again. So it's that first decline that's going to count towards this quality measure. And subsequent to that, if they continue to decline, you can't have like double jeopardy kind of thing. It's not going to count against you again. Basically, I mean, this is my opinion, they're looking for you to access that Part B service and get your PTOT folks in there to try and get the folks up and moving and have them continue to be as independent as they can for as long as they can. That's just kind of my opinion, is that CMS is hoping that by utilizing some of those Part B services, folks can get the therapies that they need in order to keep them as independent for as long as they can. I know that doesn't clearly answer your question, but that's my best guess.
Great. Thank you, Danielle. You might have already covered this, but just for clarity purposes, I want to make sure that it's clearly answered. Brenda submitted, what is the highest star rating you can get on a health inspection? 5. Okay, thank you.
Sure.
our next question is from Anne. And do they only look at the most recent survey and then the 2 prior surveys for 3 years total?
So they're going to look at the most recent survey as the highest weighted survey. So say you had your QIS survey in October of this year. That survey is going to weigh highest. And then the 2 surveys prior to that are going to be tiered in the way that we discussed. So the 1/3 and 1/6. So the survey from this October will weigh 50% of your total health inspection quality measure. Last year, so 2015, will weigh 1/3, and then 2014 would be 1/6. And the complaint investigations that fall within those years are going to contribute to that if you had any findings as a result of a complaint investigation or a revisit as a part of a complaint investigation.
Okay, thank you, Danielle. Danielle, I think you already answered this with Dante's question about the AMA, but I'm going to read it anyway. It's from Lynn, and she says, we are wondering how our long-term care residents whom are transferred to the acute setting have a 3-day qualifying stay, return to use their SNF benefit, then swing back to long-term care. How does that impact the 5-star measure?
So the question is about the long-term care resident. So I'm going to make the assumption on this question that by long-term care resident, that resident has been with you over 100 days. And this quality measure for the readmission rate is focused on your short stay folks. So those folks that have been in your facility less than 100 days. So even if it's a long-term care, in your mind, someone who is on a long-term care unit has been in your facility less than 100 days, and they go to the hospital and come back to you, use some of their SNF benefit, and then bounce back to long-term care, they would count. But if they're a long-term care resident that's been in your facility over 100 days, then it's not going to count in that measure because it's only looking at residents who are with you less than 100 days. Hope that makes sense.
Okay, thank you. We have time for a few more questions. From Lena, for the planned hospitalizations, whose data will be used to determine that the hospitalization was planned?
So that I'm not sure that I have the answer for that. I'm going to write that down as another follow-up. I'm going to assume if this is a planned hospitalization, it's going to be based on whoever the referring physician was. If it's, for instance, an organ transplant or maintenance chemotherapy, it's going to be based on the diagnosis justification code or the order code that's given from the referring physician. And so that would disqualify them. So if you have someone in your facility that has maintenance chemotherapy requiring them to exit your facility for 2 days and then come back, it's going to be that physician that orders that. But I don't want to say that without 100% certainty, so I'll follow up on that.
Great, and you can address that during our follow-up call on December 1st.
Great.
Danielle, we have a question from Anne. I'm just hoping you can go over to your weighted deficiencies slide.
Yeah.
On that slide, can you explain what the numbers in parentheses mean in the F deficiencies? So, for example, the 20 points in parentheses. So she's asking.
Yep, I isolated 50 points over 75. I don't know with certainty actually what the discrepancy is, but I can find out about that.
Great, thank you.
And I will include that for the December 1st follow-up.
Yes. Okay. Our next question is from Mark. If the resident is admitted to the ER for a reason unrelated to the NF admission, does that still count against the facility?
Yes. So if they come into your facility for skilled rehab because they had hip replacement and then they go to the hospital for pneumonia, that does count, as an example.
Okay. If the next question is from Ida. If the patient is discharged home and returned to the facility within 30 days, does it count negatively?
So this is on the emergency or so this would be the measure asking about discharge to the community. If we go back, I'm just going to pull that slide back up here. Bear with me while I get there. So these are going to be folks that were not admitted to the nursing home within 30 days of the community discharge. So if your resident discharged from the facility, went home, and then was admitted to the nursing home back, it wouldn't count on the discharge to the community measure. Not sure if she's referencing this measure or perhaps she's referencing the emergency room measure. But obviously going from home to the nursing home is not going from home to the emergency room if it was a direct admit from the community. So the only measure that I can think of in reference to that would be that discharge to the community measure.
Okay, great. Thank you. Lisa, can you just remind people on the phone how they can ask a question if they have one to ask?
Yes, ma'am. And again, that's star one to ask a question.
Great, thank you. I'm going to keep going because we have a few more minutes with our chat questions, but please feel free if you want to jump on the line to ask a question, feel free to do so. Vincent asked, what if a short stay patient requests to transfer to another nursing home? How will that affect the rating?
So with regard to the discharge to the community rating, I'm assuming is what he's asking, because it wouldn't be a transfer to an acute care setting or the emergency room. It would be a transfer from one level of care. Okay, I just see your response, Vincent. Thank you. Okay, so that's going to be kind of a lateral transfer from facility to facility, and I'm not sure if that would count against you. I don't think that it would, but I will find out. That'll be another follow-up for December 1st.
Okay. Next question is from Brenda. Can you review where we can find the 18 items to include on the EHR for transitions of care?
Yes. So that is going to be in the newly released rules of participation. And I know I sent out a link to the folks here in Maine, but I can actually see if I can pull that link up for the chat window. But there is it's a PDF that you can find right off of the CMS website that has that written down. We've also had some other quality agencies that have worked on developing kind of Cliff Notes versions of the rules of participation. But let me see if I can pull that up while we're answering questions, and I'll see if I can get that link into chat right now.
Great, thank you. And your question will be addressed at the follow-up meeting. That's the question about the parentheses, the number of points in parentheses on the weighted deficiency slide. So Danielle's going to look that up and get clarification on our follow-up webinar. The next question comes from Anna. If you know your score for health inspections based on survey, is there a way to predict how many stars that will equate to in the present year?
Ooh, okay, I might need to read that one. If you know your score for health inspections based on survey, is there a way to predict how many stars that will equate to in the present? So, wrapping my head around this question. So, if you know, you want to be able to predict the number of stars based on the potential findings for this year's survey? Is that?
Yeah, that's how I'm interpreting the question, Danielle.
Okay. I mean, so basically you could do the math. I mean, if you knew, let me just go back to that weighted deficiencies. So if you knew the range for 5, and I'm throwing this out as an example, if you knew that, I was going to go to 31 based on Chris Ryan, but I'm not sure if that's right. So if you say that you knew a 5-star for QIS was 600 points, and that you have for the most recent 2 years 400 points, or 800 points, you would need to get less than 200 points, or you would have to lose 200 points in order to drop yourself down below that 600 in order to get the 5-star. Is that kind of asking out into the Neverland? But you could do the math in that way.
Do you know, Danielle, if there's like a calculator or a tool that people could use to do that now?
I know that HCA on their trend tracker website, they do have some tools that will help calculate quality measures. I don't know for sure if that service will actually look at deficiencies in QIS surveys and predictable models for how many deficiencies you want to avoid for the next year. But I can look at that and see if we can come up with an example for the first.
Great. I think we have time for one more quick question. I'm going to address Dr. Lynn McNichol's question. Will nursing homes get a breakdown of the scores so they know where to concentrate their efforts for improving their scores, or do they just get a star rating?
So you can look at the way that well, yes and no. You can look at how you fall in your quality measures by using your monthly CASPER reports. You also can look at Nursing Home Compare for publicly reported information. In terms of the point breakdown at this level of detail, I've worked in nursing homes before and I've never been able to find a source for that level of breakdown. It's always been kind of a best guess estimate to try and figure out, similar to the question before, how do I predict if we have 3 deficiencies versus 2 deficiencies this year, is that going to drop us down a star rating or improve a star rating? So using your CASPER reports month to month and using your Nursing Home Compare is your best way of kind of looking at your quality measures and where to focus your efforts in terms of improving quality measures, because your CASPER reports are your best tool for that.
Great. I think that's all the time we have for questions. So any questions that are left in the chat, they will be addressed at our follow-up webinar on December 1st. I'm going to turn it back over to you, Danielle, for closing remarks.
Yes. Okay. Basically, just want to remind folks that we're here. There's representation in each of the New England states. You can reach out to any of us, and there will be a follow-up phone call on December 1st. I've been feverishly taking notes of the questions that I was unable to answer today, so I will make sure that we have answers to those questions for that phone call, and the information on how to log in for that call will be coming to you shortly. So I really appreciate spending the time with us today, and don't hesitate to reach out if you think of questions moving forward in the next couple of days or so. We'll definitely get those questions out to you. And take advantage of those tools that the CLIN is providing. We have resources on our website at healthcarefornewengland.org. And we also have ongoing regional webinars that are happening monthly. So we look forward to hearing and talking to you.
Great. Danielle, this is Melissa. I just want to say one last thing. So in preparation for our December 1st follow-up call, if you have a case that you want us to review during the call, we'll be happy to do that. There was a suggestion in the chat to show some real cases and walk through them. So if you have that, please don't hesitate to reach out to your state contact person that's on the slide right now. That said, thank you all for your time, and we'll talk in a few weeks. Have a great day.
Thank you so much.
Ladies and gentlemen, this does conclude today's conference call. Thank you for your participation.